Hello everyone and welcome to the Academy of Online Radiology Education blog series. My name is Amirhossein Roshanshad and I am a postdoctoral research fellow in the Department of Radiology at the University of Wisconsin-Madison. I am genuinely excited to be here and contribute to ACORE blog series. Today, we will be discussing the role of three-dimensional MR elastography or MRE in measuring liver stiffness in adults with severe obesity and evaluating its performance compared with conventional 2D MR elastography, which is currently being widely used for this purpose. Before we begin, I would like to sincerely thank my senior editors, Dr. Carrot, Dr. Stewart, and Dr. Elastography for their guidance, valuable feedback, and continued support throughout the preparation of this blog. This blog is based on the article titled Comparative Precision of 3D MRE and 2D MRE for Measurement of Liver Stiffness in Adults with Severe Obesity. This study was published in Radiology in May 26. I would also like to recognize Dr. Lucas Muller and the entire investigative team for conducting this thoughtfully designed prospective multicenter study, which provides important evidence regarding quantitative liver imaging in patients with severe obesity. To understand why this study matters, it's helpful to review the clinical context. Metabolic dysfunction-associated steatotic liver disease, or MASLD, has become the most common chronic liver disease worldwide, largely driven by the increasing prevalence of obesity. As MASLD progresses to steatohepatitis or MASH and liver fibrosis, patients become increasingly susceptible to cirrhosis, hepatic decompensation, and hepatocellular carcinoma. With recently approved therapies, such as resmetirom and semaglutide, accurately identifying and monitoring liver fibrosis has become more important than ever. MR elastography is currently one of the most accurate, non-invasive imaging techniques for assessing liver stiffness. However, severe obesity creates technical challenges that may reduce measurement precision, and until now, it has been unclear whether three-dimensional MRE offers an advantage over conventional 2D MRE. This slide compares the two imaging approaches evaluated in this study. Two-dimensional MR elastography is the current clinical standard and measures mechanical wave propagation within individual imaging slices using motion encoding in a single direction. Three-dimensional MRE, on the other hand, captures wave motion throughout an entire volume using motion encoding in three orthogonal directions. In addition to liver stiffness, it can generate other viscoelastic biomarkers, including the storage module, loss module, and damping ratio. The investigators wanted to determine whether this additional information also translates into improved measurement precision by comparing repeatability, reproducibility, and technical performance between the two techniques. This was a prospective dual-center study involving 103 adults with severe obesity who were scheduled for bariatric surgery. The average participant's age was 44 years old, and the majority were women. Participants underwent imaging at multiple time points, including baseline before surgery, after a preoperative liquid diet, and again 12 months following surgery. Both 2D and 3D MR elastography examinations were performed, and repeat scans with patient repositioning allowed the investigators to rigorously evaluate measurement precision. Image analysis was performed using automated Hepatogram Plus software, with readers blinded to participant information to minimize bias. The investigators measured liver stiffness as well as three additional viscoelastic parameters: a storage module, loss module, and damping ratio. Several statistical metrics were used to assess precision, including repeatability coefficient, reproducibility coefficient, intra-class correlation coefficients, and technical failure rates. The study included a total of 103 participants and 377 imaging visits across all participants. The average liver stiffness measured approximately 2.2 kilopascals with two-dimensional MR elastography and 2 kilopascals with three-dimensional MR elastography. Overall, three-dimensional MRE consistently demonstrated better measurement precision than conventional 2D MRE. Importantly, the investigators also observed that liver stiffness measurements obtained using 2D MRE were systematically higher than those obtained with 3D MRE, indicating that the two methods shouldn't be used interchangeably during longitudinal follow-up. Although three-dimensional MR elastography demonstrated superior precision, it also exhibited a slightly higher technical failure rate compared with two-dimensional MR elastography, particularly at 3 Tesla. Among the additional quantitative biomarkers, the storage modulus demonstrated excellent repeatability and reproducibility, suggesting that it may become a useful complementary biomarker in future studies. In contrast, the loss modulus and damping ratio showed considerably greater variability, indicating that these parameters require additional technical refinement before they can be routinely incorporated into clinical practice. So, what do these findings mean clinically? The superior precision of three-dimensional MR elastography likely results from its ability to characterize wave motion in all three spatial directions, providing a more comprehensive assessment of tissue mechanics. Improved repeatability and reproducibility for 3D CSC may increase confidence when monitoring disease progression or treatment response, especially in multicenter clinical trials and longitudinal imaging studies. However, these advantages must be balanced against practical limitations, including longer acquisition times, greater breath hold requirements, and a higher technical failure rate. Therefore, while three-dimensional MRE is promising, two-dimensional MRE remains an excellent and practical option for routine clinical imaging. The authors also acknowledged several important limitations. The study population consisted predominantly of women, relatively few participants had advanced fibrosis, and all imaging was performed using MRI system from a single vendor. Additionally, although automated analysis reduces operator variability, the results may not directly translate to centers that rely on manual image analysis. Future research should focus on improving free-breathing three-dimensional MR elastography, reducing technical failures, validating fibrosis threshold specific to three-dimensional MR elastography, and further evaluating the clinical value of additional viscoelastic biomarkers. To conclude, this study demonstrates that three-dimensional MR elastography provides significantly better repeatability and reproducibility than conventional 2D MRE for measuring liver stiffness in adults with severe obesity. Although three-dimensional MR elastography offers greater quantitative precision, its longer acquisition time and higher technical failure rate currently limit widespread clinical implementation. For now, two-dimensional MR elastography remains a reliable and practical clinical tool, while three-dimensional MR elastography appears particularly valuable for longitudinal monitoring, research studies, and multicenter clinical trials, where maximal measurement precision is essential. Thank you very much for your time and attention. I would also like to thank the Academy of Online Radiology Education for providing me with this wonderful opportunity to contribute to ACORE blog series.